Now that we've actually started with our workup about triaging the patient, starting with, is the patient stable, unstable? Do they have signs of peritonitis or impending perforation? Or do they have a mechanical obstruction that we need to address early? Then we look at the next set are the urgent, no progression, recurrence, and those who actually get worse. For those people we are treating non-operatively, then we can follow who actually progresses, and then we can remove the NG tube and start their diet if they're successful. Or if they don't, then we get to the part that they go back to urgent, that we need to do an operation. And the operation mainly has to focus on resolving the obstruction. And this would require either lysis of adhesions or a bowel resection plus minus an ostomy formation or an anastomosis, depending on the patient's status and the location of the obstruction. If a hernia is involved, you also have to consider how you're going to fix the hernia in what type of setting. Is it going to be a clean case, a clean contaminated, and is the patient optimized to decrease the risk of recurrence? So what are the numbers and the chances of you actually getting another obstruction? Because if you think about it, when you operate, you get scar tissue. And we're talking about adhesive disease. If you got scar tissue, then you operate to break down the scar tissue, then you'll develop new scar tissue. Well, why break it down? Well, difference is you have to address the current situation and try to prevent the future one. But the more urgent situation is if a scar tissue is causing an obstruction, then you have to relieve it or it will progress to perforation and may actually kill the patient.